Okay, so now we're going to go ahead and go into our substance use disorders. So these again are very common, especially as comorbids to a lot of other mental health disorders. We're going to go over some signs and symptoms of acute toxicities and withdrawals and how to treat those. So with all of these, the DSM-5 criteria is pretty similar. So I'm going to go through it once for this first one, and then just remember that for each one of them, the same criteria applies just to that specific substance. So let me just do it generally. DSM-5 criteria for substance use disorder. So here are the criteria. Basically, if a patient has 2 to 3 of these, they have a mild substance use disorder. 4 to 5 is moderate, and more than 6 is severe. So the first one is the substance is taken in larger amounts over a longer period of time than was intended. So for example, if a patient was prescribed a benzo to be taken, as needed for anxiety, and they were given 10 pills for the month and they started taking it multiple times daily, something like that. And then the next one is persistent desire or unsuccessful effort to cut down on the substance use. The next one is a great deal of time is spent in activities attempting to obtain that substance, using that substance, or recovering from the use of that substance. So lots of time involved. The next one is a craving for that substance. The next one is recurrent use of that substance resulting in failure to fulfill obligations. So now the substance use is becoming so severe that they are not able to fulfill other responsibilities. The next one is continued use despite persistent or recurrent interpersonal problems exacerbated by that substance. So even though it's interfering with their daily life, they are continuing to use it persistently. The next one is important activities given up because of the substance use, so that one kind of goes along the same lines. The next one is recurrent use in situations in which it is physically hazardous. The next one is continued use despite physical or psychological problems worsening due to use. So example, if somebody has liver cancer and they just continue to drink alcohol, even though they know that alcohol use can, far worsen liver cancer, just continue to use anyways. The next one is a tolerance to that substance. So basically, they have to continue to use more and more to reach the same effect. And the last one is withdrawal. So if you're getting to a point where if you're not using it, you're experiencing symptoms, then that's the last criteria there. So that is going to be the same DSM-5 criteria for all of the different substances. And then we'll just go through these signs and symptoms and treatment of the substances now. So the first one is alcohol use disorder. Most patients develop this by their late 20s, but it can happen at any age, often can be genetic, increased stress, other mood disorders, etc. So withdrawal symptoms, obviously a lot of us know the symptoms of if somebody is acutely intoxicated with alcohol. They're like euphoric, happy, laid back, things like that. But the main symptoms you want to remember for withdrawal, so this is more so like if somebody is a chronic alcohol user and then all of a sudden can't get alcohol and now they're experiencing withdrawal because they had to cut cold turkey, it's actually very dangerous. So withdrawal symptoms involve behavioral changes, autonomic instability, increased hand tremors, insomnia, nausea, vomiting, hallucinations, psychomotor agitation, and a big one is grand mal seizures. So seizures are highly related to alcohol withdrawal. Some of the major screening tools used for alcoholism include the CAGE questionnaire, the alcohol dependence scale, or the audit, which is alcohol use disorder identification test. One thing that you might see on physical exam of a patient with alcohol use disorder is palmar erythema. So their palms might be red, and that is an indicator of chronic use of alcohol. Can be. So treatment for this, big one is definitely counseling and support groups. Obviously AA is a big one. For alcohol use disorder, some medications that can be used are naltrexone, acamprosate, and disulfiram. So naltrexone basically works by reducing the reward of drinking by blocking opioid receptors. So because this medication is already blocking the receptors, drinking isn't going to really give you the same effect, and therefore is going to be less desirable. And then there's the disulfiram. Again, if they're taking disulfiram, which is also called antabuse, basically if they drink any alcohol, they're going to have severe nausea and vomiting. So then we have medication for acute alcohol withdrawal. Like I said, it's very associated with the tremors, the seizures, and things like that. So one medication that is commonly used for acute alcohol withdrawal are benzodiazepines, such as chlordiazepoxide or oxazepam, and these are used short term, only about 5 days. Then again, for detoxification and symptoms of withdrawal, medications can be used such as carbamazepine, which can decrease alcohol cravings after withdrawal, but this medication does have a lot of drug-drug interactions. Then there's gabapentin, which can be used for the symptoms of anxiety and insomnia associated with withdrawal. Then we've got thiamine. So thiamine is vitamin B1, and by giving thiamine to patients who are detoxifying from alcohol, it will prevent the Korsakoff syndrome, which is related to severe memory loss, and then also Wernicke's syndrome, which is associated with ataxia, dysconjugate gaze, encephalopathy. And then also multivitamin is just really good for alcoholics because they're usually very vitamin deficient. So a couple notes to think about in alcohol-related disorders is you don't want to use bupropion because, like I said earlier when we were talking about depression, it lowers the threshold for seizures, and patients with alcohol use disorder have a high risk for seizures. So you don't want to use bupropion to treat these patients if they have comorbid depression. And then just to kind of talk about how alcohol works in the body, it agonizes GABA receptors. So this is what causes the central nervous system depression, euphoria, ataxia, impaired judgment, coma, and potentially death. So that is what occurs when a patient drinks alcohol, especially a lot, but that is what causes those symptoms related to alcohol use. So next we'll go on to cannabis. So patients affected by cannabis-related disorders are typically younger adults that also suffer depression, anxiety, social anxiety, and PTSD. I saw this a lot in my psych rotation with a lot of people self-medicating with marijuana to treat their anxiety because it's the only thing that helps. So it's very, very common to see. Signs and symptoms of acute intoxication include euphoria, anxiety, uncontrollable laughter, increased appetite, inattentiveness, forgetfulness, and restlessness. And then signs of withdrawal include depressed mood characterized by apathy, lack of motivation, loss of interest in typical activities, isolation, insomnia, and decreased appetite. So when you're thinking about different substances and symptoms of acute intoxication versus withdrawal, you kind of want to think opposites. So in acute intoxication, when they're really happy and euphoric and increased appetite, and then withdrawal, you're going to see the decreased appetite, loss of interest, loss of, any emotion and things like that. So for physical exam then, we have the acute intoxication of cannabis, including tachycardia, dry mouth, and conjunctival injection, whereas withdrawal includes difficulty concentrating and irritability. The treatment here, again, is counseling. You want to use a gradual taper of use, especially if the patient is a chronic user. You don't want to cut it off cold turkey, especially if their body is so used to having the marijuana. So you want to gradually taper the use. And then again, you can treat symptom-wise for withdrawals. So you can use alpha-2 adrenergic agonists or beta blockers for tachycardia. You can use benzodiazepines for the panic attack symptoms, and off-label use of first-generation antihistamines for anxiety and restlessness, neuroleptics for psychosis. So those are just some of the medications that can be used for withdrawal symptoms of cannabis. So when we're thinking pathophys, the THC component is the partial agonist at cannabinoid 1 and cannabinoid 2 receptors. The reason for abuse potential is due to the cannabinoid one receptor stimulation. So the next one we have are the hallucinogens. So there's two kind of broad categories of hallucinogens. There's the just hallucinogens, and then there's dissociative drugs. So they all kind of fall into this whole section. So some examples of hallucinogens are LSD, which is commonly called acid, psilocybin, I don't know if I'm saying that right, but that's also known as shrooms, the peyote or mescaline, DMT, MDA, which is also called ecstasy and Molly commonly. And then some dissociative drugs include PCP, which is commonly called angel dust, ketamine, and DMX or dextromethorphan, which is also like a cough suppressant medication that can be used and abused, essentially. Risk factors for hallucinogen-related disorders include young adults, patients with co-occurring psych disorders, performance anxiety, and can also be genetic. And we want to think of short-term and long-term effects when it comes to these drugs. So short-term effects of using these drugs include nausea, intensified sensory experiences, change in sense of time, appetite loss, sleep problems, panic, paranoia, psychosis, and uncoordinated movements and numbness. So I think when a patient is on one of these medications or drugs, they have a high risk of potential harm to themselves or others because they're just very, dissociated from themselves or, reality in a sense. So those are some short-term effects. Long-term effects include persistent psychosis, such as like visual hallucinations, paranoia, disorganized thinking, and mood changes, speech problems, memory loss, and suicidal thoughts. So again, very dangerous drugs that are unfortunately used by a lot of people, and definitely something to look out for. So on the physical exam, if someone is acutely intoxicated with one of these drugs, some things you could see are tachycardia, excess sweating, dry mouth, and dilated pupils. So look for the large pupils. Pupils are something I feel like are asked about a lot, so just think hallucinogens are the dilated pupils. Then when we go down to opioids, we're going to see the more pinpoint pupils on acute intoxication. So just think about pupils. It's commonly seen because it is something you can commonly assess for on physical exam. So some severe effects that you can see with the hallucinogens include grinding of teeth, severe tachycardia, hypertension, psychomotor agitation, intracranial hemorrhage, myocardial infarction, aortic dissection, DIC, rhabdomyolysis, seizure, and dysrhythmias. Also with PCP especially, you could see nystagmus, so it's when the eyes are like going back and forth, back and forth. How do we treat this? So basically, again, we're treating the symptoms. So first line therapy would be cognitive behavioral therapy. Next, for symptoms such as severe hypertension or psychomotor agitation, especially related to MDMA, would be benzos. Again, short term, you want to just treat the symptoms and severe effects with a benzo, but you don't want this to be long term. I have a note in here that says avoid beta blockers. This is a question I got. You don't want to use the beta blockers for this severe hypertension and psychomotor agitation related to these drugs. Something you can also use for MDMA ingestion, if it was within 1 hour, you can use activated charcoal, especially if it was a high dose of this drug. Activated charcoal is something that can help. Moving on to inhalants. So inhalants are what you would think of as like commonly seen like household items, essentially that people inhale to get a high. So some of these things include solvents such as gasoline, lighter fluid, and glue, aerosols like spray paint and hairspray, gases such as butane lighters, propane tanks, ether and chloroform, and nitrites such as room odorizer, leather cleaner, and video head cleaner. Things that can lead to people abusing inhalants include stress, psychological disorders. This especially kind of starts in a younger population due to like the inability to get these other types of drugs and a low education level. So those are just some risk factors involved. So what you're going to see as acute side effects of these inhalants are things like slurred speech, lack of coordination, euphoria, dizziness, mood swings, nausea, vomiting, headache, and coughing. Long term, if people are using these over and over, you're going to start seeing liver and kidney damage, hearing loss, bone marrow damage, loss of coordination of limbs, delayed behavioral development, and brain damage. So some withdrawal symptoms of this include nausea, loss of appetite, sweating, insomnia, and mood changes. Physical exam for these patients would be some things that you might see that are more common would be like an erythematous rash around the mouth from contact dermatitis. Again, these substances are hazardous substances, so these patients are inhaling them. You're going to see some contact dermatitis around the mouth. Facial flushing, unusual breath or body odor, this is a big one. Tachycardia, wheezing, tremor, loss of consciousness, hallucinations, nystagmus, and poor attention. So definitely look out for these, especially in younger patients. This is a clinical diagnosis, and essentially what you're going to do to treat is just treat the symptoms they're having. Definitely cognitive behavioral therapy as well. And now going on to the opioid-related disorders. We kind of touched on this slightly earlier. So this commonly occurs starting in late teens, early 20s. Especially in patients with a family history or with a history of chronic pain, a lot of people will start because they were prescribed an opioid for like maybe after a surgery or a procedure or injury, and then they get hooked and can't get off of them. So let's start first with the overdose symptoms. So the overdose symptoms include like a stupor, meiosis, cold and clammy skin, cyanosis, coma, and respiratory failure that can possibly lead to death. So triad you want to remember when you're thinking of opioid overdose is coma, pinpoint pupils, and respiratory depression. So opioids just kind of like slow things down, and the pupils get really small, unlike the hallucinogens where they get big. So one way to remember this is, I think like opioid, like the O in opioid is like a tiny little O. For the pupil is a little O. And then for hallucinogens, like they're seeing hallucinations, so they have these big eyes. I don't know. It's a way to remember it if you can't remember it. So withdrawal symptoms include opioid craving, anorexia, anxiety, irritability, nausea, insomnia, abdominal cramping, involuntary muscle spasms, and piloerection, which is like when your little hairs on your arms stand up, like goosebumps. And again, so on physical exam, this is something you want to look out for, especially in the drug-seeking population. If a patient comes in, they have increased respirations, increased blood pressure, sweating, yawning, lacrimation, rhinorrhea, the piloerection, tremor, dilated pupils, vomiting, diarrhea, and tachycardia, you might want to consider they are in opioid withdrawal and they're seeking opioids. So if you have a patient that's coming in literally asking for an opioid prescription and they have these symptoms, might be a good time to think about maybe they're addicted to opioids and we need to do something about it. So again, remember, if a patient is overdosed on opioids, they're going to have the pinpoint pupils really small, but if they're withdrawal, they're now going to have the dilated pupils or mydriasis. Meiosis would be pinpoint, mydriasis would be dilated. Another just like screening assessment for opioid use would be the COWS assessment. So just a little buzzword to look out for. The COWS assesses for opioid use disorder. So what do we do to treat this? Well, for withdrawal, what we want to use is either methadone or buprenorphine, which are long-acting opioid agonists, and these are tapered over days to weeks. So these are essentially opioid agonists that don't have as much as an effect of the stronger opioids, and basically they can be controlled a little bit better. And so these will prevent withdrawal symptoms because they are kind of giving the body the same effects as the opioids did, and they will reduce the further opioid cravings. Another thing that can be used is clonidine to help with the withdrawal symptoms. So methadone, buprenorphine, clonidine, you want to think for opioid withdrawal. For opioid intoxication, acute intoxication, you want to think naloxone, which is Narcan. This is an opioid antagonist, and it prevents the euphoric effects of opioids pretty rapidly. So this is something that is commonly used to rapidly reverse symptoms of opioid overdose. The next one that can be used is Suboxone, which is buprenorphine and naloxone combined. And this can be used to help somebody wean off of opioids in a more controlled way. Again, it has the buprenorphine, like we talked about earlier, that is used in withdrawal, and naloxone combined. And then you can also use pentazocine, which is partial agonist antagonist of the opioid receptors, or Tawin, which is pentazocine with naloxone. So there's a couple different options there. Again, non-pharmacological treatment includes cognitive behavioral therapy and 12-step meetings. So the next category we're going to talk about are the sedative / hypnotic / anxiolytic related disorders. So this is essentially benzodiazepine abuse. Again, risk factors for a lot of these are really similar. So if they have another substance use disorder, if they have chronic pain, personality disorder, depressive disorder, sleep disorder, certain muscular disorders, especially, in patients that were prescribed a benzodiazepine for a certain condition such as anxiety and then got addicted to it. So withdrawal symptoms of benzos are similar to that of withdrawal symptoms of alcohol. So you're going to see seizures, constant state of fear and panic, insomnia, irritability, increased tension, headaches, palpitations, anorexia, muscular pain, panic attacks, hand tremors, difficulty concentrating, psychotic reactions, nausea, and hallucinations. So again, because benzos are used to treat acute alcohol withdrawal, so you want to think like the symptoms of withdrawal of benzos are similar to that of alcohol. Withdrawal symptoms you might see on physical exam, like I said, include tremor and difficulty concentrating. Overdose symptoms of benzos, so a patient who acutely overdosed might present with altered mental status, slurred speech, hypotonia, drowsiness, respiratory depression. So again, similar to a patient who overdoses on or takes an extreme amount of alcohol, you're going to see kind of similar symptoms there. So kind of think that benzos and alcohol kind of present the same with their overdose and withdrawal symptoms. So again, the treatment is to slowly taper off the benzo. This can be pretty difficult, especially if a patient has been on it for a really long time, because there can be, like I said, the severe withdrawal side effects. So it's something that just has to be done really, really slowly and really controlled under the control of, a psychiatrist. As far as treatment goes, for acute intoxication, the benzo antagonist that is known is flumazenil. But this is not commonly used because if the patient is a chronic user of benzodiazepines, this could actually exacerbate the symptoms of their withdrawal. So it's not always used. It's more so just use supportive care if they're having respiratory depression, intubate, just supportive care until they can get the drug out of their system. As far as withdrawal symptoms, you want to use a benzo to treat it. However, the benzo you want to use is diazepam, which is the longest acting benzo, and then you want to slowly taper off of that. So it's just a more controlled way to get somebody off of using these chronically. So a couple of the most commonly prescribed benzodiazepines that you'll probably see are Xanax or alprazolam, Klonopin or clonazepam, and Ativan or lorazepam. So a lot of these patients will be on this for things like insomnia, anxiety, and things like that. And it's important to control what patients are on these and that they're only used for a short term. These aren't meant to be chronic medications. So moving on to stimulant disorders. So stimulants are medications such as methamphetamine, cocaine, Adderall, Ritalin. These are commonly used to treat ADHD, but can also be very much abused. So Risk factors include family history, high stress, or exposure to violence or crime. So, symptoms of acute intoxication include hyperarousal, impaired judgment, euphoria, elevated blood pressure, transient psychosis, and hallucinations. When I think of the symptoms of intoxication and withdrawal of these, I kind of think of coffee because coffee has caffeine. What does coffee make you feel like? Hyper aroused. You can feel your heart rate going crazy. You can feel your blood pressure increase when you drink too much coffee. So that's kind of the way to remember it if you can't really keep everything straight. However, when you get to like overdose situation on these drugs, you could start seeing seizures, severe hypertension, psychosis, hallucinations, stroke, rhabdo, and myocardial infarction. So definitely not something to mess with, right? Long-term effects include dilated cardiomyopathy and pulmonary hypertension. So definitely some severe long-term effects that can occur if patients are chronic users of stimulants. Withdrawal symptoms include craving, severe fatigue, depression, paranoia, anhedonia, anxiety, increased appetite, irritability, depression, dysphoria, nausea, palpitations, and psychotic reactions. So now when we're going to our physical exam, overdose on the stimulants, you could see hypertension, hyperthermia, tachycardia, and mydriasis, the dilated pupils. Again, so if you're having too much stimulant, think dilated pupils. Withdrawal, tremor, and sweating. For treatment of these, again, you're going to want to slowly taper off of the drug. You can use antidepressants to help with the depressive symptoms of withdrawal. Again, CBT is definitely helpful for all of these. And for acute cocaine toxicity, because you're getting all those tremors, hallucinations, one thing that you can use short-term, again, are benzos. However, you don't want to use these long-term, like we said before. As far as pathophys goes for these medications, they increase activity in serotonin receptors, so that's just something to keep in mind if you're asked kind of a pathophys-related question to the stimulants. So lastly, for substance use disorders are our tobacco-related disorders. So again, this includes nicotine, smoking, vaping, etc. Risk factors for this include other psych disorders, genetics, lower education levels, a lot of veterans, and lower income levels. So some of the symptoms associated with this involve the urge to smoke within 30 minutes of waking up, ranking the first cigarette of the day as the most important, and smoking regularly throughout the day. So these patients are just constantly wanting to smoke another cigarette throughout the day. Withdrawal symptoms include irritability, restlessness, anxiety, insomnia, difficulty concentrating, fatigue, and increased appetite. So these symptoms can be relatively severe, especially in a patient who kind of cuts this off cold turkey. In patients with tobacco-related disorders, you want to make sure you're screening and checking for other comorbidities related to smoking, which is literally every medical condition in the book. You could probably see a risk factor is smoking. So you want to make sure you're screening patients, especially for hypertension, hyperlipidemia, diabetes, cancer, and just basically a full workup, because smoking can cause so many terrible effects to the body. So you just want to make sure you're really following these patients with a close eye. So treating these patients, the first thing again is counseling. Very helpful for all of these conditions. The next thing you can do are the nicotine replacement therapies. So this can be seen in like nicotine gum and patches, which just give the body small amounts of nicotine, and you could slowly taper off that way versus just cutting off cold turkey and experiencing all of these terrible withdrawal symptoms. Another medication that can be used for smoking cessation is bupropion, which is, like we said, was also used in depression. This is a dopamine and norepinephrine reuptake inhibitor and can help with smoking cessation. The other one that can be used is varenicline, which is a partial nicotine receptor agonist. So this is just another medication that can potentially be used to help with smoking cessation. So just another little pathophys tidbit about these are nicotine binds to nicotinic acetylcholine receptors, and this causes a release of dopamine, norepinephrine, serotonin, endorphins, and acetylcholine. But when you're thinking of, okay, where does the nicotine bind? It binds to the acetylcholine receptors. That's a question I had, and I got that wrong as well. So that's one thing you want to keep in mind when you're thinking of nicotine and where it binds.